Hi, good evening, everyone, and welcome to this Diabetes Africa event, the second in the series of Everything You've Always Wanted to Ask.
Diabetes Africa is a non-profit organization. We were established in 2019, and our goal is to improve diabetes care for people based in Africa, but also people of African origin globally. And we do this by communicating, connecting people, and part of what we do like this is to raise topics and increase awareness about things that are very important to diabetes care.
And today we're going to be talking about getting the diagnosis right for diabetes in people of African or Caribbean origin. We're joined today by two great speakers, one, Dr. Gideon Malawa, and second of all, Dr. Glenys Williams, who will introduce themselves more thoroughly just before their session. I'd like to thank Novo Nordisk for enabling this event series to happen. They haven't had an input into the agenda, content, or speakers, but we're very grateful for them supporting us to be able to talk about this topic. As always, please interact with us in the chat. If you're having any tech problems, please reach out to us individually. However, if you have questions, just general questions about the topic we're speaking to, please make that please put that in the general comment section so that either the Diabetes Africa team or the speakers can respond to your questions. We'll also have a Q&A session at the end, so any unanswered questions as we're going through, we can discuss them then. So today we're going to go through the different subtypes of diabetes. If there are any particular subtypes that might be more relevant for people of African or Caribbean origin, some different ways to differentiate between the different subtypes, and then some case studies where we're going to need your inputs to determine what diagnosis the person actually had in the end. Gideon, can you tell us a bit about yourself, please?
Thank you very much for your introduction. My name is Dr. Gideon Malawa. I'm a consultant physician in diabetes and endocrine, and I'm based at Queen's Hospital, Romford in East London. I'm also a founding member and treasurer to the Tanzania-UK Healthcare Diaspora Association, also called TUHIDA. And in part of London where I work, I see a lot of patients with diabetes. And this area has got a mixed population, Afro-Caribbeans, Asian, and Caucasian. And therefore, we've got a wealth of experience in terms of managing these patients with diabetes.
Thank you, Gideon. So I wanted to start off by asking you, what are the subtypes of diabetes? And of those subtypes, which is most relevant for people of African or Caribbean background?
So when we talk about the types of diabetes or subtypes of diabetes, we talk mainly about the three major types. That's type 1 diabetes, type 2 diabetes, and in women who are pregnant, they can have diabetes in pregnancy, also called gestational diabetes. Then you get other rare form of diabetes, which we say maybe other forms of diabetes.
Before we move on, I'm wondering if you could just say the normal diagnostic tests that you would use to diagnose the three: type 1, type 2, and gestational.
So if you look at type 1 diabetes, first of all, you go with shorter history, age of presentation, and sometimes if they present dramatically, when they are very unwell, they come to hospital, these patients can present with building up acids in their body, the so-called diabetes ketoacidosis. And therefore, it is when they present to hospital in acute setting, you can check their blood test looking for whether they've got acids. We look for pH, we look for ketones in the urine or blood, and also we look at the sugar levels. So they will have high sugar levels, they will be building acids in their bodies called acidosis, and also they will have ketones either in the urine or blood, and that is easy to diagnose. But if they're relatively young, they present with high sugar levels, they are thin, they're not obese, these patients are more likely to be type 1. So the presentation can be dramatic or just slow, but look at the age, and therefore you can say that are they type 1 diabetes? And if they present with the so-called diabetes ketoacidosis, that's a diagnosis.
And would you look for other tests? Like, would you do C-peptide? Would you do any autoantibody or antibody tests as well to confirm type 1 diabetes?
So I talked about presentation, but in terms of testing, if the patient comes with the so-called diabetes ketoacidosis, that's clear cut. You can say you've got type 1. But if they come with just high sugar levels, but they're not building acids, they're younger age, you want to prove it by using anti-GAD and anti-ILS antibodies, because we know that type 1 diabetes is a condition which is related to immune defect, and therefore it's autoimmune condition. And if those antibodies are positive, it backs you up that you have got type 1 diabetes. And some of these patients, if they presented early, they don't necessarily need to present with dramatic, being very unwell with DKA. They can present with just high sugar levels, being tired, and therefore you prove that they are type 1 with additional antibodies test.
And if you could explain to the audience what's the difference between C-peptides, GAD, and islet cell antibodies, that would be useful.
So for somebody who is who are in type 1 diabetes, we think that these patients are not producing insulin at all, but there's total deficiency of insulin. Some of them, when they present first time, they might be still producing some insulin, but to measure that they're still producing insulin, you have to measure something called a C-peptide, which is a protein, and that is high when somebody is producing insulin. And in some patients, they can present with type 1, but they've got something called honeymoon period. They are type 1, but they're still producing insulin, and eventually they will end up not producing insulin at all. So the definition of type 1, we say that these patients are not producing insulin at all. So C-peptide is a measure of saying that is a patient still producing insulin? And if that's the case, have we got the diagnosis right? So the type 1 diabetes, they shouldn't have high level of C-peptide because we assume that they are not producing insulin at all. The antibodies to islet cells, which are within the beta cells of pancreas, is just that we know that type 1 diabetes, the trigger is maybe environmental factors such as virus, and with that, you get antibodies against the virus, but those antibodies, they can go and attack the beta cells, islet cells, and therefore destroying the beta cells which produce insulin and leading to type 1 diabetes. I hope I've tried to explain.
Yes, that's great, Gideon. That's really good. So we've gone over the 3 major types of diabetes, which is type 1 diabetes, type 2 diabetes, and gestational diabetes. And you've gone over the testing for type 1 diabetes and normally when that should happen. The 2 that's missing, but I guess are similar, but have differences, is for type 2 diabetes and for gestational diabetes. How do you go about diagnosing those 2?
So for type 2 diabetes, most patients, they will come with maybe they go to a well-manned clinic, they go for just review. And as part of that, we say you are now 50 years old. We're going to check all the blood tests, including tests for diabetes, maybe glucose level. You can have high glucose level, maybe fasting more than 7. You can say you've got high levels. And if you get that is very high, we do something called oral glucose tolerance test. You give a glucosate, which is a sugary drink. Then you do blood tests initially fasting, then 2 hours after that. You can look at the levels. But now we are allowed to use HbA1c. We can use HbA1c to diagnose diabetes. So you can use HbA1c, also do oral glucose tolerance test. So the type 2 diabetes patient, most of the time they present maybe with other presentation we are doing blood tests, they might say that they've been tired, as I told you that their history and presentation is a bit prolonged. It won't be as dramatic as type 1, unless there's precipitation or there's a trigger for them to be very unwell. If they come with infection, maybe chest infection, we pick up that they've got chest infection, but they've got a sugar level of 30, and therefore they're older, they're obese. We say, okay, you are type 2, you do blood tests, they're not building acids, and therefore they are type 2, given the older age, given the other factors such as being overweight. And if you go deep in their history, maybe they're eating unhealthy food. So it's less dramatic compared to type 2, type 1 diabetes is in older patients. And that's a key factor to try and differentiate between the two. For gestational diabetes, is part of the antenatal checkup. So in UK, for instance, we screen for gestational diabetes in all mothers, pregnant women who are ethnic minority, because being of ethnic minority of Afro-Caribbean or Asian, you are at risk of getting type 2 diabetes or gestational diabetes, and therefore we screen them for that. If you've got a first-generation relative who has got diabetes, those mothers, those pregnant women are screened for gestational diabetes. If they had a baby before who are bigger babies, they are born bigger, more than 4 kilograms, we screen for diabetes, whether they're Afro-Caribbean, whether they're white, we screen for gestational diabetes. So that's how we go about screening them.
Okay, thank you again. That's great. So we've covered the top, the most common. Now I've got three on my list that I'd love to discuss with you. If you could just give us a top line of what they are. So we've got MODY, we've got ketone prone or flatbush, and then we've got LADA. So I'm wondering if you could give a top line of what they are and the diagnostic test that you would use for each of them. You know, what test would confirm or exclude each of those three?
So in today's discussion, we discussed about different types of diabetes, but most importantly, we want to talk about the condition which has affected or is more common in Afro-Caribbean, that is the LADA, which is late onset diabetes of adults, or it's also called autoimmune, latent autoimmune diabetes of adults. It's common in older patients who can present as type 1 while they're old and they've got positive antibodies. In terms of ketone-prone type 2 diabetes, it's common in Afro-Caribbean men who are obese, they're older, and they want to present, they resemble like somebody, they build up ketones in their body, they're acidotic, but they get better once you control their sugar levels, and they might not need to be on insulin, or they need only tablets, or just that control. But this can represent again with that, with the same presentation again. So that is ketose-prone type 2 diabetes, also called Flatbush diabetes. Flatbush is a place in New York, if I'm not mistaken. It's a place in New York where the people who are living around that area, they are Afro-Caribbean, they are coming with presentation which resemble that like they're type 1, but actually they just have ketones, they get better.
Great, thank you, Gideon. The final one of the three is MODY.
So there's a group of condition called monogenic diabetes, okay? If you look at a proper type 1 diabetes, what is the pathophysiology? It's a combination of environmental factors plus genetic susceptibility. But the genes involved in type 1 diabetes are multiple genes, okay? So you get somebody who is genetic prone to getting type 1 diabetes. You add on environmental factors such as viral infection, and therefore it triggers the chain of getting autoimmune condition, forming antibodies, and therefore type 1 diabetes. In this group of MODY, which is one of them, I'm not going to go into detail, is that you get this patient having just one gene defect and therefore causing diabetes. So MODY, maturity onset of diabetes in the young or monogenic diabetes is you get a gene defect, but it's a one gene defect. And some patients, they need only tablets. Some patients might need insulin, but they go with other features. They are very unique, they are very specific. And when we look after this patient, even where in the setting where I work, if I get patients who they're young, they are not even, they don't look like type 1 or type 2, we send for genetic studies. And we've got a center where we send these patients. So it's highly specialized in that sense. I hope I've tried to explain what MODY is in terms of that is a single gene disease compared to type 1.
Okay, no, that's great. Thank you, Gideon. So what? Two things. Firstly, in terms of the testing, would you do the same C-peptide and antibody testing for someone who you suspect as having MODY?
I think we do HbA1c, we do everything, because that is part of everything. But if you look at this patient, if you assume that, okay, they are young, I'm going to give them insulin. If you look at them, some of them, small insulin requirement causes low sugars, it causes hypoglycemia. So you have to start suspecting that is the diagnosis right? Somebody is maybe on 3 units of short acting with maybe 4 units of long acting. It's not your typical type 1, and therefore you have to revisit your diagnosis.
The diagnosis.
You have to speak to other people. And where I work, in the setting where I work, we've got a center in Exeter where we send patients for, they are good at doing genetic testing for MODY. If you are not sure of the diagnosis, discuss with other centers to get a proper and correct diagnosis for them.
You've alluded that ketone-prone / flatbush and LADA are subtypes to be looking into if you have a person presenting with diabetes symptoms who doesn't quite fit the type 1 or type 2 typical diagnosis. Is there anything someone treating or caring for a patient of African or Caribbean origin that they should be looking out for in terms of diabetes diagnosis?
When it comes to the ketone-prone type 2 diabetes presentation, it's dramatic in the sense that when these patients, they come in acute setting, they're unwell, you do blood tests, they're building up acids, okay, in their body by doing blood gas. They've got high sugar levels, but they get better very quickly once you use insulin to bring down the sugar level. We think that when they've got very high sugar levels at the beginning, the high sugar level is toxic to the beta cells. So trying to bring down the sugar levels, make them get better very quickly. But also because they're overweight, they've got more fat, and therefore there's a risk of having high fat levels, which can cause toxin to the beta cells, but also formation of the ketones, which that's why they will say that ketone-prone type 2 diabetes, which gets better by itself.
Okay, so for a healthcare professional that's seeing someone who was initially diagnosed as type 1, but they seem to have a high body weight, they should be aware of somebody who, when they treat them with insulin, the insulin requirement goes down very quickly. So that should be a red flag for someone that they might have a flatbush subtype of diabetes. Okay, and for
add one thing, sorry. So
yes,
what's important is the ketone-prone type 2 diabetes. When you do the antibodies, they are negative.
Right, that's important.
So that differentiates from LADA. Okay, so they come like they look like DKA, like type 1, but you do everything. The insulin requirement goes down. They get better quickly. You do antibodies are negative. So we said that they came with DKA, but the antibodies are negative. They're Afro-Caribbean, they're obese, and this fits in with the diagnosis of ketone-prone type 2 diabetes or flatbush diabetes.
And so when these, oh, go on, please, go ahead.
So for the LADA, we know that, so I've seen patients before. So you see a patient who said that I was diagnosed as type 2 diabetes 4 months ago, but when they come to us, So they were on metformin, for instance, and the glucoside. They come, they are unwell because the trigger for them to become unwell was maybe infection. But when they come, they are in DKA. You do antibodies, they are positive. So this someone who is 50, he was told that he got type 2 diabetes 2 months ago. Now he comes with DKA. They've got positive antibodies. They've got latent autoimmune diabetes of adults or late onset diabetes of adults, the so-called LADA. They've got positive antibodies. In ketone-prone type 2 diabetes, the antibodies are negative.
Okay, thank you, Gideon. That's a very important differentiation. And in terms of type 2 diabetes, we're hearing that younger and younger people are being diagnosed, and that it could, and sometimes we're seeing this in people of African or Caribbean origin. Is that something that you've seen in the clinic? And what advice do you have for other healthcare professionals who are not sure of a diagnosis?
So that's a very good question. I work as a physician. I work in the front line in acute setting, but also I do clinics. But I will say this, we have got a changing face of type 2 diabetes. So there's a changing face of type 2 diabetes in a sense that if we talked about type 2 diabetes 50 years ago was for older patients who are maybe slightly overweight. But because of changing face of diabetes and changing lifestyle, most younger patients are getting now type 2 diabetes. We have got younger patients who are maybe they don't exercise, they eat unhealthy food, and therefore they're obese. So if you look at how type 2, the contributing factor to type 2 diabetes, one of them is obesity. So with increase in obesity, there's increase in type 2 diabetes, including type 2 diabetes in the young. So my advice to whether our fellow Afro-Caribbean healthcare professionals is that look out for younger patients who present with high sugar levels. You don't necessarily have to say that they are type 1. If they are obese, they might be type 2, especially in Afro-Caribbean. I have done pediatric clinics as part of training. I've done transitional clinics. By transitional clinics is a clinics where you get 15 to 16, 17 years old before they graduate, before they move from children's service of diabetes to adult service. And we've seen those group of patients, some of them, they've got high BMI or they're overweight, and therefore they're type 2 diabetes, and you have to treat them as type 2 using metformin as any other type 2 diabetes. So in summary, there's a changing phase of type 2 diabetes simply because of lifestyle changes, lack of exercise, increasing number of obese patients, including children, and therefore high numbers of type 2 diabetes in children.
So essentially, the takeaway from that I'm understanding is if a healthcare professional sees a young person who has a high blood sugar and could be overweight, the assumption shouldn't be type 1 diabetes. They should go ahead and do additional testing, such as looking for antibodies or assessing C-peptide before they make the decision that the young person has type 1 diabetes. Is that right?
We can do that. We make sure that we cover all the bases. And with that, we once you initiate somebody on treatment, we follow them up. And with that, we learn a lot from patients. The patients I've seen in acute setting, you assume that they're type 2, and within weeks, you know that whatever you've given is not working, and therefore you have to revisit your diagnosis. It's about, these are chronic conditions. We establish a rapport and relationship with patients long term. We look after them, and therefore we make sure that they are free to come back to us. We communicate with them, and we get the diagnosis right by being in close communication with them and following them up without just leaving them alone with a diagnosis which is not very clear.
That makes sense. And in summary, if I was the people joining in for this event, if we were to say someone of African or Caribbean origin comes into the office, they're presenting with a subtype of diabetes, either way. If it doesn't fit type 1 or type 2, of the other subtypes that it could be, from what you said, it could either, one of the high possibilities is ketone prone or flatbush or LADA. Have I got that correctly?
That's correct, yes.
Okay, that's very useful. And you've gone through how someone would present for ketone prone and also how someone would present for LADA. So that's very clear. We have some of our audience are not based within the UK. And so we've had a question from Stephen, and it's actually on how would someone identify the subtypes, the less common subtypes of diabetes in a lower resource setting?
So it's also a very good question in terms of what subtype of diabetes in lower resource setting. It might be very difficult, but if I add this question, try to answer this question with the previous question. If a patient comes with presentation and they are not sure, if you starting them on insulin is the right thing, because at least you will not miss the type 1. And that initiation of insulin, if you think that they need that, you need to refer to a bigger center. The diagnosis can always be revisited. But if you delay starting somebody on insulin, and if they are type 1, they can go on DKA, and that's the wrong way. So yes, if you're not sure, get help from a bigger center. If you're not sure, you go to a facility that you think that this patient has got diabetes, you're not sure whether it's type 1, starting them on insulin initially is not a wrong thing to do. We always revisit. We have got a few patients within my center where we start them on insulin. Within 3 months, we review them. Then we escalate, we downgrade the treatment. So if the patient is ketosis prone or LADA, to try and diagnose them, maybe it will be difficult because you need to get to a bigger center where they've got antibody testing. So the same way, you're in doubt, yes, you think that, okay, it's type 2 diabetes patient, you're going to start them on tablets. But because you are not sure, you can say that I've seen the patient, I've started them on tablets. The LADA patient will not improve on just tablets. The sugar level will remain persistently high. If they eat healthy, if they're exercising, if they're not overweight, you can say that, I'm not sure, can we review this patient? Can this be LADA? Referring to getting support from bigger center. If it's a ketosis prone, of course, you can say that I've given this patient, they came with very high sugar levels. I've given them maybe medication. If they come to your center, can you check their pH, their blood gas? Can you check their ketones? Can this be ketosis prone? So in a smaller setting, it'll be difficult, but I think that working in collaboration with bigger centers, and now with the help of telemedicine, that we are communicating better as the healthcare professionals. And that's one thing which COVID-19 pandemic has brought, that people are working together better using telemedicine. And it's not only in the global north or Western countries, back home, every individual has got a mobile phone. So we can do communication through WhatsApp in a bigger center, saying I've got this patient with 50, of course, without naming names, you anonymize patient confidentiality, then you get advice in those settings. So that's why I can say that working together with the bigger centers will help you to get the diagnosis right if you are in a smaller setting, a small hospital, or in rural areas back home in rural resource setting.
Okay, thank you, Gideon. So from what I've understood, when looking at the less common subtypes of diabetes, you're saying the main thing that people want to avoid is missing someone who has type 1 diabetes who might be heading towards a DKA or is in DKA. So it's always better to give insulin in the first instance just to exclude that. And from what you said, if the person has flatbush or ketone prone, that insulin requirement will come down very quickly. And then you'll have an indication that that person might have ketone prone. In this case of LADA, because there is actually a long-term insulin requirement, that need will likely remain somewhat stable over time. And in the flip side, if someone's on tablets, if somebody with LADA, it wouldn't have much effect. And then someone with flatbush or ketone prone, it might help to reduce the blood glucose levels and thus helping to resolve the issue. So that's kind of like a more clinical way of assessing between the two different subtypes, which might be more common for people of African or Caribbean origin.
That's correct.
Okay, great. That's fine. Is there anything that I haven't asked you, Gideon, that you think is important to mention when we're having a focus on African and Caribbean origin people?
I think we've tried to cover most of the things in my setting. One of my interests is global health. So I'm a founding member and a treasurer to Tanzania UK Healthcare Diaspora Association called TUHIDA, and we do global health activities. As a part of that, I've attended a conference back home in terms of East African Diabetes Study Group conference, and I learned a lot from that conference in terms of stigma in terms of the diagnosis of diabetes, but also the fact that at the time, if you go back maybe 10 years ago, we didn't have a registry, a database of, if you go to the Ministry of Health and ask them that, can you tell me how many type 1 diabetes patients you've got in the country? They're not able to provide that. If you say that, can you tell me how many type 2 diabetes patients you've got in the country? The lack of data is an issue, has been a factor back home, and keeping data will help us to understand how our patients present and how to help them in the future and offer them the best possible care and hoping for better outcome.
Absolutely, absolutely. I do believe that data collection is important. And actually, since you mentioned it, in the UK, there's still some progress to be made in terms of how much data there is for people of African and Caribbean origin in relation to their diabetes. So I think there's actually some commonalities there. Thank you, Gideon. That was a great run through of the subtypes of diabetes, the different ways that you would test to confirm a diagnosis, how you would confirm a diagnosis clinically, and also some of the red flags that people should be aware of when they see somebody of African or Caribbean origin presenting potentially with an atypical or less common type of diabetes. Much appreciated. We're now going to go to Glenys, who's going to run us through some case studies, which will involve interactive polls. Thank you, Gideon.
Thank you.
So hello, everyone, and thank you, Bernadette, for your kind introduction. My name is Dr. Glenys Williams. I'm a GP with specialist interest in diabetes and medical education. I'm going to lead on 3 case studies which are reflecting making diagnosis in diabetes for the African and Caribbean population. And at the end, I hope to deliver some key takeaway messages. So the first case study involves a child who is presenting with concerning symptoms. Our second one is a gentleman with a 7-day history of headaches and weight loss. And our third case involves a 60-year-old who is a cafe owner. So Aisha is 10 years old. She's of West African ethnicity, and both parents have already been diagnosed with type 2 diabetes for a few years. She complains to her mother one Saturday afternoon that she's tired, she's very thirsty, and has stomach pains. Her mother takes her glucose meter out because she suspects that this could have something to do with diabetes and measures a random blood glucose. This turns out to record 22.5 millimoles per litre. So the concerned parents take us straight down to casualty. There it is noted that Aisha is above the 99th percentile for child weight growth chart. They also remark that she has acanthosis nigricans around her neck. This is dark pigmented patches, which is found in the axilla, in the groin, and in the neck, and is often associated with underlying conditions like type 2 diabetes. It is noted she has no retinopathy, and the pediatricians are called down for an assessment. The pediatricians decide to admit her and have a period of observation, and it seems that her fasting blood glucose on average is 15 millimoles per litre, and her postprandial readings are around 20 millimoles per litre. All the urine analysis checks are negative for ketones throughout her stay in hospital. She has normal renal function and no microalbuminuria. Her HbA1c, though, comes back at 104 millimole per mole. The old currency, that would be about 11%. So whilst in hospital, she's hydrated with intravenous fluids and put on sliding scale insulin. And prior to discharge, she's put on a basal bolus regime of glargine and Novorapid. My mum is really unhappy about this because they're about to go on holiday to Turkey. And she's thinking about taking all the paraphernalia and having a 10-year-old, to start on insulin and to be monitoring. And mum is convinced that her daughter wasn't extremely unwell prior to admission, and she'd recovered so well, and asked if the consultant could let them go on holiday on tablets. And he flatly refused, saying he would only discharge her on insulin. But they agreed to a follow-up in the outpatients for an oral glucose tolerance test, C-peptide, and insulin islet cell and GAD autoantibody screen. Okay, so I think it'll be useful just to see what the rest of us think about this. What do you think is the diagnosis for Aisha? We have 3 options, and we're going to put this out on a poll to see what our audience thinks. Is she a type 1 diabetic? Is she got type 2 diabetes, or has she got maturity onset diabetes of the young?
Wonderful. So we're getting our first votes in here. Very interesting. You should see a poll screen pop up there. I know some people are answering the chat, but if you could answer the poll and then maybe give an explanation in the chat. I'll give it a few more seconds and let's share the results.
So, very interesting what people have thought, and I'll tell you what actually happened. And Aisha is actually my patient. She was diagnosed as the youngest patient in Hounslow to have type 2 diabetes. Her MODY screening, which was done in Exeter, came back negative. She had negative autoantibody screen. She had insulin levels of 11.7 milliunits per litre. She had a positive oral glucose tolerance test. So mum was so happy that she could come off insulin, and she was started on metformin 500 milligrams twice a day. Now, what we noted was that the family lifestyle meant they had a diet that was rich in carbohydrates, and they hardly engaged in physical exercise. So the parents who had had type 2 diabetes and had not achieved target for HbA1c became even more motivated to help their daughter. So with the help of a dietitian, and signposted them to the World Food Carbon Cals website, which reflects information on diet, the African Caribbean diet. It was very helpful to them, and Dad improved his diet to reach individual target HbA1c for himself. He still struggles with physical activity. He says he works hard as a Tesco manager and is too tired to engage in physical activity. Mum, who had a BMI greater than 40, qualified and had bariatric surgery, and she not only improved her HbA1c, but improved her diagnosis of chronic kidney disease from stage 4 to stage 3. Mum's latest HbA1c is 64 millimoles per mole. Aisha, it turned out, was having midnight feasts where she would stock, chocolate, sweets, biscuits under her bed to, enjoy that when everybody else was asleep. And we engaged in a 4-year program of gradually increasing her physical activity outside school, at the weekends, and after school. And she was fortunate at puberty to lose a bit of weight, but she's still, for a child of 14, around the 80th percentile for weight, and her HbA1c has improved to 84 millimoles per mole. So I think the target for Aisha is to try and down. So our next, he's 5 years old. He's a gentleman of Nigerian ethnicity and works as a security guard. Prior to his presentation, he was diagnosed with type 2 diabetes for the last 2 years and was proud to have such excellent control and compliance and had an HbA1c of 45 millimoles per mole. His BMI was 29 and he had complications of hypertension and microalbuminuria. Therefore, he was on the maximum dose of metformin 2 grams a day. He was on atorvastatin 40 milligrams a day, indapamide 2.5 milligrams a day, and ramipril 10 milligrams a day. Microalbuminuria, as we know, is a risk factor for cardiovascular disease, which is the reason why he was on atorvastatin and the antihypertensives, and ramipril as well. So at presentation, it occurred 2 months after the start of the pandemic, and he presented, he said he'd been unwell, but in the last 7 days to presentation, he had headaches, vomiting, polyuria, and a dramatic 4 kilograms. As lockdown, he had stopped working and he was spending a lot of time at home, and he went straight down to casualty. There, he had some blood tests done and he was noted to have sodium 145. His random glucose was 43.3 millimole per liter and CRP was 100. Urine ketones were 3+. He had glycosuria and was COVID negative. His blood pressure was 121/90 and he was tachycardic at a pulse rate of 120 and apyrexia. His HbA1c was 88 millimole per mole. It was noted by the casualty officer that he was not distressed and remained calm, and this seemed to be contrasting with the results that were remarkable and made them refer him on to the medics for assessment. After assessment by the medical registrar, he was admitted for hydration and started on a basal bolus regime of Glargine and Novorapid. He was not happy with this because he felt he'd had really good control up to this time, and he was trying to work out what could have triggered for him to get into this state requiring insulin. The consolation was to discharge him on mixed dose insulin twice a day. At the time, they also agreed to do GAD, C-peptide, and islet cell anti-screening. So, reflecting on case history so far, what do you think is the diagnosis for HOPE? We're going to do another poll, and this time I'm hopeful that we will all agree the right diagnosis for HOPE. So there are 4 possibilities. Could he have hyperglycemic, hyperosmolar, non-ketotic state? Could he have ketone-prone diabetes, otherwise known as Flatbush? Could this be a case of control requiring intensification of treatment? Or could this be an undiagnosed late onset of type 1 diabetes?
Great, thank you, Glenys. So as before, you should see a poll popping up on your screen. Please answer the question. We've got 4 options, as Glenys has alluded to. That's great. We've got 60% of people voted. I'll give you 3 more seconds. Share the results. So we see Flatbush is the main answer.
So HOPE is a 45-year-old with ketone-prone diabetes, otherwise known as Flatbush. Ketone-prone diabetes was first diagnosed in an area in Brooklyn, New York, amongst African Americans. They present with a similar clinical symptoms and signs to HONC. They're often middle-aged, mildly obese, but they have negative GAD and negative islet cell antibodies. But the difference between HONC and ketone-prone diabetes is that they present with ketoacidosis. So as you noted, HOPE had 3+ ketones in his urine. This episode for him was triggered by the reduced activity due to the COVID restrictions, which meant he was staying at home, and also that he consumed 6 cartons of pineapple juice over a 4-day period. It was one of those marketing ploys for an economic benefit with adverse health benefits. So he had bought 6 packs for another free 6 packs. And I think he realized at some point that he was consuming sugar. So he felt that the carton said no added sugar, but the concentrate already had sugar. So here again, it was a case of not having enough information, and by us just directing him to the World Foods, Carbs and Cows website, he understood a lot more about his diet to not make these sort of mistakes. The management going forward was that I had to take him off insulin because after changing his diet, he developed recurrent hypoglycemia. So we stopped his insulin and I started him on canagliflozin, 100 milligrams a day, and increased it to 300 milligrams in about a month. And he continued on metformin 2 grams a day. I had noted he had microalbuminuria that was just being treated with ramipril. But as you know, microalbuminuria is a significant marker of cardiovascular disease risk. So putting him on canagliflozin was going to be cardioprotective as well as renoprotective. It lowered his blood pressure, and therefore I could stop the indapamide. And his blood pressure was averaging about 115 over 76. And the weight that he had lost prior to admission, he'd gained going on insulin, especially as he developed hypoglycemia and was eating more then. And his weight stabilized on canagliflozin. His HbA1c in 3 months was back to 48 millimoles per mole. Right, so our third case study is Ishmael. He's a fine-looking gentleman, 60 years old, is a cafe owner of Ethiopian ethnicity, and is an active cyclist and eats a diet rich in carbohydrates whilst being vegetarian. Prior to this presentation to his GP, he had no previous comorbidities and felt he was, quite a fit individual. He presented with fatigue and weight loss, which was gradual, of about 4 kilograms in a 3-month period. But notice he was waking up at night a couple of times to go to the loo, and even during the day, he had polyuria. He had no family history of diabetes. So he had some blood tests done on presentation, and it showed he had a random glucose of 15 millimoles per liter. His HbA1c was 64 millimoles per mole, had normal renal function, but his ACR, albumin-creatinine ratio, was raised at 30 milligram per mole. His BMI was 28, and he had no retinopathy. So, reflecting on the diagnosis, the GP rightly so diagnosed him as type 2 diabetes because his HbA1c was 64, and he was symptomatic. They started him on oral therapy, and within 12 months, he had achieved maximum oral therapy. We know from the UK PDS that 50% of patients after 3 years would have achieved maximum oral therapy. So he achieved it in a very short space of time, and he was still symptomatic, and his HbA1c had not improved significantly at 70 millimoles per mole. So what is the right diagnosis for Ishmael? Could he be a type 2 diabetic patient requiring insulin for optimization? And maybe he's been diabetic for a bit longer than he recognized. Could it be that he's got late onset autoimmune type 1 diabetes? Or is it just he's not been complying because he thinks he's such a fit guy and he's trying to do everything with his diet and exercise, and it's just poor compliance? Let's have a poll.
So as before, you should see the poll question pop up on your screen. About 50% of people have answered. So once again, I'll give about 5 seconds before I show the results. 4, 3, 2, 1. Okay. This one's much tighter, but most people think it's type 2 diabetes requiring optimization.
So Ishmael turned out to have late onset autoimmune type 1 diabetes. And this is not surprising because even in the African Caribbean population, the incidence of LATs is similar to that of the other ethnicities. It's really interesting that the second generation immigrants have a similar incidence for type 1 diabetes as the rest of the indigenous population. So it may be that there are environmental causes which are far stronger in these cases than genetic causes. So how did we manage Ishmael? We confirmed his diagnosis with the fact that he had low C-peptide levels, he had GAD antibodies positive islet cell autoantibodies. So we stopped the oral medication and we started him on basal bolus. And often in these cases, they require very low doses to manage. And he soon had excellent control with an HbA1c of 48 millimole per mole and was feeling so much better in himself. So we've presented 3 typical cases, and I'd like to say these are all 3 real patients of mine. And the key messages I'd like to leave you with is that type 2 diabetes is got a higher incidence in the African Caribbean population, about 3 to 5 times from various studies. It does seem to occur at an earlier age. And as we know, early diagnosis achieves metabolic memory, which reduces the chance of complications and gives people a better life experience. I think lifestyle modification, as recommended by NICE, we need to push at all times. And the importance of that is to achieve weight loss, because diabetes remission is achieved with significant weight loss. If patients lose 70% of their excess weight, they can go into remission. And there are various strategies nationally. Some in my area in Northwest London, we have Diabetes Rewind, but you can also signpost patients to websites like the World Food Carbs and Cal, and other websites that give structured education, because power with knowledge can help people make decisions to change their lives. Flatbush diabetes is common, and in the African, Caribbean, and Asian population more than other ethnicities. So think about it. They do have similar presentations, and the difference is the presence of ketoacidosis. As NICE recommends, individual risk assessments so that the appropriate medication can be chosen to improve and reduce complications of diabetes. Recent studies demonstrated that Diabetes UK shows that the African Caribbean population tend not to be exposed to the use of the GLP-1 and the SGLT2 medications, which are very useful in helping weight loss, as well as reducing cardiovascular mortality, renal mortality, and all-cause mortality. Late onset autoimmune diabetes can present in African Caribbean patients, so be mindful of looking for this in a patient who is not responding with oral therapy. And know that the type 1 diabetes incidence has a closer significance with the environment than with ethnicity. Thank you so much for listening.
Thank you, Glenys, for going over those case studies. They were definitely insightful. And thanks, everyone, for taking part in the polls. I hope there's a lot to take away from the different cases. Next on, I would like to introduce Aisha, who's going to give some lived experience about the challenges that can happen in diabetes diagnosis. Aisha, I'm wondering if you can introduce yourself, please.
My name is Aisha Thomas, married with 2 kids, a boy and a girl. I was initially diagnosed diabetes 23 years ago as a type 1, and was given the option straight to start insulin, and which I did, but I never adhered to the rules, and I had a lot of complications along the way, which involved miscarriages, I had kidney failure, hypertension, high cholesterol, and retinopathy. These are all the complications I had, including others. And when my daughter was 11, yeah, she was also diagnosed with diabetes. But with her, when I took her in, she was diagnosed straight as a type 1. But I know it's what she eats. So I had to tell them to give me a week for me to see how I can control her sugar levels. So we were admitted in the hospital, and she was monitored. And at the end of the day, she was diagnosed as a type 2 diabetes.
Wow, that's quite a series of events. And it must have been quite shocking for you as a parent to have your daughter diagnosed with diabetes so young. And I guess most people would assume it would be type 1 diabetes, but in the end, you're saying it was type 2 diabetes. Do you remember any tests or any discussions that the diabetes team did with you to determine if it was type 1 or type 2 diabetes?
When they did the blood test, they told me they have to start on insulin because her sugar levels were too high, and because of her age, because she was quite young. With people her age, they normally diagnose as a type 1. But I asked them to just give me a week. If within that week, her sugar level doesn't come down, then they can start on insulin. So we were admitted in the hospital, and I controlled everything she eats, and we did lots of exercise whilst there. And so be it then. So she was a type 2. She was diagnosed as a type 2.
And I guess, yeah, it's interesting because if you weren't in a hospital setting, the diagnosis likely would have been type 1 diabetes immediately. But in a way, it's good that you were in a hospital setting being supervised by the team, so you could, experiment to see if changes to diet would actually change your daughter's blood glucose results, which it did. And I think it's a little bit surprising that there wasn't a conversation with you about the different, tests that could be done to confirm which type of diagnosis your daughter had. But I guess, how long is it since your daughter was diagnosed?
She's I think it was 2016 or 2015.
2016. So it's been some time.
Yeah.
Another question I have is, do you feel like the diabetes team factored in you and your daughter's ethnicity into the discussions that were had about the diagnosis?
I don't think so.
Nothing comes to mind.
I might be wrong, but I don't think so. I think just when they did the test, because of her age, they straight away considered that she was a type 1 because of her age.
Okay, that makes sense. Is there anything that you would like the healthcare professionals who have joined this meeting to take away from the meeting? What's the number one?
The number one thing, I think they need to first of all look at the culture of the individual, and also they need to, as I ask for a week, sometimes give them time to go and think about the diagnosis, to go and see what they can do. Maybe as what they did with me, leave the patient in a hospital setting where they can be monitored, just in case anything go wrong, they can be able to attack it straight away. And also they should take into consideration that with my experience and my child's experience, that age doesn't mean that because you're young, straight away they can be a type 1.
Yes, absolutely. That's a great takeaway. And it's one of the core things that we're speaking about in this meeting today is when there's somebody of African or Caribbean origin, it might be worth doing additional tests. If they have someone that seems to fit the bill for one type, it might be worth doing additional tests just to confirm the diagnosis, as was the case with your daughter, who initially the healthcare professional team thought was type 1 diabetes, but it was actually type 2 diabetes. So that's a great takeaway. Is there anything I haven't asked that you would like to talk about?
And another thing, I actually spoke to the consultant, my daughter. I think they need to have, because my daughter feels as if she's the only one that's a type 2 diabetes. That being a young child, they need to have more activities for diabetic type 2 diabetes children, like my daughter.
Yes.
Like, so that they don't feel as if they're different, don't feel belong. And I think people need to be educated more about diabetes, especially children from a young age, especially black children, considering our food is more starchy than other foods, and we eat loads of starch. So if they start teaching these children from younger ages by having all these classes, like this team, how do they call it now? Team events for children, concentrating on children with diabetes, I think it will help Black children a lot.
Okay. Well, thank you, Aisha, for sharing your experience. It's been great to hear about the path that yourself and your daughter went through to your diagnosis. Yes, please, everyone in the chat, please have your questions for Aisha and any questions that you have for the Q&A session. Thank you.
Thank you very much for having me.
We've got quite a few questions that have come in advance. And so I'd like to bring Glenys and Gideon back to the conversation. Just going to ask you to unmute. So while they're doing that, the first question I will pose to whoever comes back first. Gideon and Glenys?
Yeah, thank you.
There we go. Thank you, Glenys. Goodness me for technology issues. So since you're the first on, let's go to you. So we have a question from Martha Stewart asking about HbA1c variants and fructosamine. I was wondering if you could speak on that, please.
Yeah, fructosamine, it's not a common test. I probably do it about 3 times a year. It's in comparison to HbA1c, and in a sense, it's a replacement for the HbA1c when you need to monitor glycemic targets because the HbA1c in that particular case is invalid. So the cases where an HbA1c test would be invalid would be someone with a hemoglobin variant like in sickle cell, HBSS, HBSC or CC, someone with hemolytic anemia where their hemoglobin is quite low. It's also used when you want to adjust treatment in a very short space of time because the fructosamine only reflects on the last 2 to 3 weeks. So if for whatever reason you want to adjust medication really fast, you can use it. And the test itself represents glycylation of amine, which is the albumin protein. So it can be inaccurate in cases where we've got low protein, like in protein loss from the gut or from the kidney. So I've got a patient who is sickle cell and diabetic, and so I use this test for him just 3 times a year. It's not meant to be used for screening because apparently the levels are similar in a well-controlled patient with diabetes as well as a patient without diabetes. So those would be the instances that you would use fructosamine.
That's excellent. Thank you very much, Glenys. I'll actually go to you again next before coming on to Gideon. So we've had a question from Michael and also from Haswa about one, can children develop type 2 diabetes? And then the second question is diabetes in adolescents. Do the same diagnostic criteria apply?
Yeah, so one of the cases was about a patient who was 10 years old who developed type 2 diabetes. So absolutely, we are seeing as the global trend is the diabetes is increasing worldwide, and even middle-income countries are having a high cardiovascular disease mortality as a result of diabetes. So yes, you can diagnose type 2 in children and adolescents. In Europe, there's not a lot of data for African Caribbean patients. And in Europe, the data I came across was published in 2015, which showed that the incidence of type 2 diabetes in the African Caribbean children and adolescent population is about 1.5% of the type 2 population. So it's really low, but it's increased in the last 10 years. And the greatest prevalence is in the UK, but I can't actually give you the prevalence in the UK, but it's really low. I mean, I worked in secondary care at West Middlesex Hospital for about 25 years, and I can think of about 5 patients who were diagnosed under the age of 16. So the test is the same. The only difference is the gold standard test, the oral glucose tolerance test. The measurement of glucose that you use to do the test, you need to think about the weight of the child. So it's 1.7 grams per kilogram. The maximum is 75 grams of glucose. So the test is the same in the terms of the measurement of fasting glucose, and postprandial levels are the same as with adults, but the actual dose for the test might vary based on the weight of the child.
Thank you, Glenys. I wanted to check with you, Gideon, because you now currently work in a different setting, hospital setting. What is your experience of the rate of type 2 diabetes in adolescents? Are you encountering that?
Thank you very much for the question. It's a very good question. And most adolescents in secondary care, they're under the so-called transitional clinics. So that's a special clinic for those patients who are from the age of maybe 15, just before they go beyond 16 years old. They are looked after in adolescent clinics. But yes, I've seen patients who are moving from pediatric clinic to adult clinics who are obese and they are type 2 diabetes. And you have to treat as such as type 2 diabetes.
Okay, great. Thank you. Thank you, Gideon. Thank you, Glenys. Gideon, this next question is for you. It's from Yemisi. They would like you to address insulin resistance, polycystic ovary syndrome, or PCOS, and African and Caribbean origin, please.
So that's also is an interesting question. It's a valid question in this setting, simply because we know that in patients with polycystic ovarian syndrome, the majority of them are obese. And if you're overweight, there's a tendency of insulin resistance. And then these patients, they've got high insulin levels, and therefore they are prone to getting type 2 diabetes. So for polycystic ovarian syndrome, the patient I'm seeing in not diabetes clinic, I'm seeing them in endocrine clinic. They come with irregular periods, as will be the presentation. And if you try and take proper history from them, phenotypically, when you look at them, they'll be obese and they will have irregular periods. And as a part of screening for that, we say that, can this be a polycystic ovarian syndrome? And because we know that there's a link between polycystic ovarian syndrome and type 2 diabetes, we check for HbA1c, and some of them, they can be pre-diabetes. So yes, there's a link between type 2 diabetes and the polycystic ovarian syndrome in females of Afro-Caribbean origin because of obesity, high levels of insulin, and therefore insulin resistance and type 2 diabetes as part of physiological mechanism.
That is great. Thank you, Gideon. That was a clear explanation. You mentioned obese, and this might be a tricky question. I'm going to pose it to both Glenys and Gideon, and others who have knowledge of this in the chat, please feel free to contribute. There's some data showing that obese, or the risk for type 2 diabetes at certain levels of obesity, is different in African and Caribbean population, let's say Black populations overall. Would you like to speak on that? I'm going to go to Glenys first, if I may, please.
Yeah, it's really interesting. So there's been some recent data published in the Lancet this year about ethnicity-specific BMI cutoffs for obesity based on type 2 diabetes risk. So the BMI risk that has a significant incidence of type 2 diabetes in the white population is 30. And that's the definition of grade 1 or obesity. And if you then say the incidence at a BMI of 30 in a white individual of diabetes, type 2 diabetes is say 10 patients per 1,000 patients. You then look at the Black British population, the BMI equivalent to that same incidence is 29.9. If you look at the Black African in the UK, the BMI equivalent to that incidence of type 2 diabetes is 29.1. If you look at the Black Caribbean, it's 26. If you look at the Indian, Nepali population, it's 24.2. Sri Lankans and Pakistani fall at 23.2, and the Bangladeshi fall at 21.2. So it shows then that if we're trying to identify and diagnose undiagnosed patients or people at risk, we need to look at different cutoffs for BMI based on your ethnicity. And I think Bernadette has kindly put the slide up that demonstrates that. So I think the take-home message from this is, now that we've got diabetes risk scores that we're using to identify the patients who are at risk of diabetes, it helps because we will select these patients based on their BMI, but different BMIs for different ethnicity, use the risk score, and then decide who you want to do a follow-up test, like a gold standard test, an HbA1c test. I find the diabetes risk score very, very useful. I don't know if the audience are aware of it, but you can actually go online and you do the score yourself. And it has scores over 25. It's been validated to show that a score over 25 will make you a type 2 diabetes. If your score is between 16 to 24, you could be at risk of diabetes or be an undiagnosed type 2 diabetic patient. If you're 7 to 15, you're likely to be at risk of diabetes with age. And if you're 0 to 6, you're low risk of diabetes. And the points it uses to give you the score are 7 points, which are all non-invasive. They're based on age, sex, ethnicity, family history of diabetes, BMI, waist circumference, and hypertension. And I did this for myself, and I was surprised that I turned out as having a score of 7, which shows that I am at risk of diabetes with age. And the advantage of knowing this is not only can you go and get screening with HbA1c, but you can begin to change your lifestyle and, with diet, exercise to prevent diabetes, which is probably the best, thing we can do for ourselves.
Thank you, Glenn. That was extremely clear and comprehensive. Gideon, I don't know if you have anything in addition to add to that.
I think what Dr. Williams has just said, I think is correct, and I don't have anything to add to that.
Okay.
And in acute setting, we tend to see type 2 diabetes, but with other issues, and therefore I know Dr. Williams in GP setting, they are doing a very good job in terms of looking after this patient and screening for diabetes and preventing them to come to hospital.
Brilliant. Thank you, Gideon. Thank you, Glenys. We have 2 questions left. The next one is for Gideon, and it's for Gideon, and it's from Oluwafemi, which is how to confirm a diagnosis of diabetes insipidus.
So that is a very good question. It's an interesting question, which even in our setting, we have to differentiate between diabetes mellitus and diabetes insipidus. In the layman language, we tend to tell patients that you've got sugar diabetes, that's diabetes mellitus, and if they've got diabetes insipidus, we call it water diabetes, because to try and just differentiate and not to confuse between the two terms. So in diabetes insipidus, the patient with diabetes insipidus, there's a gland called pituitary, and the posterior part or the back part of that gland stores a hormone called ADH, which controls thirsting. So in the patient with diabetes insipidus, they're not producing enough, or they're not storing enough of that hormone because there's some sort of damage, and therefore they'll be passing a lot of water. And in this case, that's why it's called water diabetes. They're passing liters and liters. So the way we differentiate, that's one aspect. For diabetes mellitus, which is sugar diabetes, patient will be passing a lot of water, but also if you test in that urine, they will have sugar levels. Now, to try and differentiate this, so diabetes insipidus is endocrine disorder, which is due to lack of a hormone called ADH, and therefore the patient is not able to hold on to water. They pass a lot of water. They are thirsty most of the time. So you can do that to try to confirm it. You can do something called water deprivation test. And that can be a different topic in future talks. But what I want to make sure is very clear, even in our setting here in UK, a patient with diabetes insipidus, when they come, they're confused with a patient with diabetes mellitus. And I've had a patient in my ward they've got diabetes insipidus, but we are checking their sugar levels. So it's very important to differentiate between the two. That's all I can say.
Thank you very much, Gideon. That was a clear explanation, and it actually validates the question, because if you're struggling with it also, if there's some difficulties differentiating diabetes mellitus and diabetes insipidus, even in a secondary care setting, for those in a lower resource setting, for example, that must be a very challenging scenario to deal with. The final question is, oh, I've lost my train of thought. The final question is from Charles in the chat. Should there be any caution around use of SGLT2 inhibitors with people who might be diagnosed or misdiagnosed with ketosis-prone type 2 diabetes or Flatbush? Who should I go to? Gideon, you seem ready to answer that one.
I think that's a very good question, valid question. And since the introduction of the so-called SGLT2 inhibitors, I think in our setting, we've been using most of them, and we have seen the complication of that. The common complication is maybe recurrent water infection or genital thrush, but also we are seeing patients with the so-called euglycemic diabetes ketoacidosis. They've got normal sugar levels, and therefore they can have, but they're acidotic. So once somebody has had, or they are prone to getting that DKA, based on my limited experience, I will try to avoid in giving this patient SGLT2 inhibitor, because they're more prone to getting that in that setting. I hope I've tried to answer the question.
That's a clear explanation from my perspective. Thank you very much. Before we round up the event, I'd like to get some insights from people in the audience. While I'm doing that, I'd like to thank hugely Dr. Glenys Williams and Dr. Gideon Malawa for their input in the event, and also the contribution of Aisha from a lived experience. That was hugely valuable. And also thank you to everyone who's participated in the chat and made this event so insightful and interactive. So if you could please answer the poll, which should be popping up on your screen now. Once you've done that, I wish you a fantastic evening. Please follow us on our social media handles. Our website is www.diabetesafrica.org. This is event 2 of the series. We have 3 more coming up. We'd love to see you at those other events. Have a lovely evening, everyone, and speak to you soon, again soon.
Thank you. Bye.
Bye.
It's merciless, it won't wait for us to change.
Thank you very much. Bye.
Thank you very much.
Thank you,
God bless
everybody.
you.
Thank you.
Figure out what to say. Oh,